I open this academic ceremony in which Mr. Farooqui will defend his academic thesis measuring the potential impact of immunization on demand for antibiotics and infectious disease-related out-of-pocket expenditure in India. I welcome you, of course, and wish you lots of success. Also, a hearty welcome to your supervisors, Professor van Schaik, who's present here, and Professor Babu and Dr. Karan, who are online. Also, the opponents, whom you will meet later, 2 of them online and 3 of them here present. And, of course, a welcome to all the guests that are looking now at the streaming all over the world, I think. But before we start the opposition, we give you the opportunity to tell us and your friends and family and colleagues what you have been doing in your thesis.
Thank you very much. Good afternoon, everyone. And here in the committee, as well as other colleagues and friends who are watching me online at different places, I would like to take this opportunity to thank Honorable Pro-Rector and esteemed members of the Assessment Committee for giving me this opportunity to present my work. So I'm Habib from India. I'll be presenting the thesis measuring the potential impact of immunization on demand for antibiotics and infectious disease-related out-of-pocket expenditure in India. Just to give a small background, as we all know, that infectious diseases remain one of the major causes of morbidity, mortality, and economic losses, not only in the low and middle income countries, but also in India. And unfortunately, in countries with mixed health system, where private sector is a dominant player, households have to borne out-of-pocket expenditure for treatment and care. And this results in enormous burden and economic impact on the poorer households. This also has a potential impact on equity at the societal level. So we developed a conceptual framework to understand the economic burden pathways, and as you can clearly see that the poor households lack the resources to invest in the health and prevention of the diseases because of their ability to pay, which results into higher probability of disease, infectious disease, and hospitalization, as a result of which they have to pay enormous burden, enormous amount of monies from their pocket, which results into a health shock. And these health shocks also have a dimension related to loss of work, and which results into a loss of the income, which results into a coping strategy, as a result of which they reduces investment and other important entities such as education and nutrition. This brings them into a cycle of poverty trap, which is like a poor health leading to poor income. And this leads to deepening of the poverty. And we need to understand these pathways and mitigation measures to bring them out of these poverty trap. So my thesis actually deals with 5 different dimensions of the infectious disease-related economic burden and measures associated with the reduction of these particular burden. So the first objective deals with the estimation of equity at the level of the households. So we use the data, which is national sample survey data, which is a nationally representative data collected by National Sample Survey Organization, which is a body of Ministry of Statistics and Implementation. It has a sample size of around 113,000 households and 555,000 individuals. So we used a microeconomic cost of analysis approach to estimate the economic burden. And we tried to develop a framework to understand the burden across 5 wealth quintiles. So as you can clearly see that the poorer households have the highest burden in terms of a share of households' non-medical monthly per capita expenditure, both for out-of-pocket expenditure as well as in terms of the wage loss, which is to the tune of 153% and 38%, which is much higher as compared to the richest wealth quintiles. This leads to the distress financing at the level of the households. So what happens is these households, in order to address these treatment expenditures, they borrow or sell assets. And as we can clearly see that the poorest households, around 24% households reported borrowing or sales of assets because of distress financing. So this proves the conceptual framework that we presented before, that how it leads to deepening of the poverty in the poorest households. And as we also know that the immunization is one of the most effective and the cost-effective measure to address the problem of the infectious diseases. And India has one of the largest publicly financed universal immunization program. So we try to understand different dimensions and their impact on addressing the problem of infectious diseases in the universal immunization program. So we looked at the equity impact of the program. We looked at the impact of the program in terms of economic impact at the household level. We also looked at the impact of two major interventions that happened in the program, which is introduction of rotavirus vaccine and the intensification of the program. So for this analysis, we also used the same data, but this time we used a different framework called as benefit incidence analysis, which helped us to estimate the share of immunization service utilization and the distribution of the public policy across the 5 wealth quintiles. And we estimated concentration curve, which is a measure of inequality. And this graph demonstrates what is concentration curve and how we measure the equity impact. So as we can see, that blue line is the Lorentz curve. It represents the distribution of wealth within a population. And the red line, which is at 45 degrees, is what is called as line of equality. And we can say that if everyone, irrespective of the wealth, has the same value of health outcome, which is full immunization in our case, then ideally the concentration curve should fall on that particular line. Now we estimated this for public sector and the private sector, and as you can see, that the concentration curve for the public sector immunization services falls on the line of equality, representing that it is, has equal distribution among the poor and the rich households. However, the concentration curve for the private sector immunization services falls much below the line of equality, which demonstrates that it is much, it has a rich distribution as compared to the public services. So that demonstrates the highly inequitous distribution of services in the private sector. Then we also looked at the distribution of the public subsidy on the immunization services, and we realized that the concentration curve for the public subsidy is much below the line of equality. And here again we see that this is much, it's pro-rich in the distribution. And as I said, we also looked at the distribution impact of the immunization program on household level, infectious disease occurrence and associated out-of-pocket expenditure and catastrophic expenditure. So the same data set we used to analyze the impact of the universal immunization program. And this time we used the analytical framework of case control approach, where the exposure to the universal immunization program was considered as an intervention, and the households with the immunized children were considered as those exposed to the UIP program. And here we can clearly see that after adjusting for all the potential covariates, that the probability of infectious disease-related hospitalization was around 10.7% less in the households with exposure to the program, whereas compared to the unexposed households. And similarly, the probability of infectious disease-related outpatient consultation was 5.4% less in households exposed to the program as compared to the unexposed. And consequently, this is also reflected in their expenditure on the treatment and care. And we see that the households which were exposed to the program had 0.5% less households reported out-of-pocket expenditure, and 0.7% less households reported catastrophic expenditure, which demonstrate that the program has a potential impact in improving the saving rates or reducing the disease-related economic burden at the household level. And as I mentioned about the potential impact of the introduction of the new vaccine, which is rotavirus vaccine, we know that if you go to private sector, at least in countries like India, you have to pay from your pocket to get the immunization services. So an introduction of a vaccine in the universal program, which is free at the point of care, should ideally reduce the sales of these vaccines in the private sector and shift the burden of the household from out-of-pocket to the government sector. So we examined this using another data, which is called as farmer track data. This is also nationally representative data. And this data is collected by market research agency. So here the analytical framework that we use is called as interrupted time series analysis. And we use a Poisson regression. And we looked at the intervention, which was introduction of the vaccine in the program. And we looked at the changes in the vaccine, rotavirus vaccine sales in the private sector. So these graphs demonstrate what happened with the introduction of the vaccine in the universal immunization program. As you can see, On the x-axis is the time, and on the y-axis is the rotavirus vaccine monthly sales. And a dashed vertical line represents the intervention time. So the important thing to note here is the post-intervention regression line and the slope of the post-intervention regression line. As we can clearly see here, that in the 3 states, Haryana, Rajasthan, and Uttar Pradesh West, we see the slope of the regression line going down, which clearly demonstrate that after the introduction of the vaccine in the universal immunization program, the private market sales has gone down. And this is a long-term impact. However, in other 3 states, Kerala, Tamil Nadu, and Uttar Pradesh East, we see a marginal increase in the sales. And this could be due to the reasons that in the states of Tamil Nadu and Kerala, they are rich states in terms of per capita income, and people probably prefer to still remain in the private sector because of the opportunity cost to go to the public sector. The 5th objective is about estimation of the potential impact of the intensification of program on demand for the antibiotics. We know from modeling and other empirical exercises that a reduction in the disease should ideally reduce the demand for the antibiotics. So we use the same data and using the same analytical framework of interrupted time series analysis. This time we try to measure whether there were any changes in the antibiotic sales after the periodic intensification of the program. And what we see here again is the post-intervention regression line. This is also capturing this time the seasonality of the prescription of antibiotics. Remain broadly constant for the fluoroquinolones at the country level, but for trimethoprim and sulfamethoxazoles, there was a reduction in the demand for the antibiotics. However, for other antibiotics, which is cephalosporins, macrolides, and broad-spectrum ampicillins, there wasn't a decrease, but counterintuitively, there was a slight increase of 0.5% for cephalosporin and macrolide, and 0.9% for broad-spectrum penicillins, increase at the monthly rate. And this could be because of several reasons. One of the reasons is over-the-counter availability of antibiotics in our country. So in summary, what we demonstrate is that infectious disease-related economic shock disproportionately affect the poor households, which is clearly demonstrated through the distress financing. The utilization of the public sector immunization services was equal in rich and poor households. However, the distribution of the subsidy was more pro-rich. We also demonstrated that the universal immunization program had a positive impact on reduction in the out-of-pocket expenditure and catastrophic expenditure at the household level. We also demonstrated that the introduction of the rotavirus vaccine in the program resulted in decrease in the sales in the private sector, which has a positive impact by reducing the out-of-pocket expenditure on the households. However, there was a limited impact of the periodic intensification of the program on the antibiotic utilization. So what are the policy implications of this research? One of the core policy implications is we need to strengthen the financial risk protection measures, especially the measures related to protecting the poor and the vulnerable people. And one of the mechanisms is expanding the access and eligibility criteria for the public insurance program. Another dimension is about strengthening the social security mechanisms. And especially, we know that in the informal sector employment, we should encourage the public and the private sector employers for the provision of the sick leave for people who are on informal employment, and also should suggest the insurance agencies to consider covering wage loss for the informal employment. With regards to the program itself, we recommend increased financial allocation to the program, which is really essential to expand the basket of the vaccines and also essential to reach hard-to-reach areas and vulnerable population. Furthermore, better targeting of this program would help increase the immunization rate, which ideally would reduce the reduction, lead to reduction in the disease and reduction in the demand for the antibiotics. I'll stop here. Thank you very much for your time.
Thank you, dear candidate, for a very interesting presentation. We're now going to start the opposition, and the first opponent is also the chair of your assessment committee, and that's Professor Kals. He's professor in effective diagnostics in general practice at the University of Maastricht. Professor Kals.
Thank you very much. Dear candidate, first of all, congratulations on completing a wonderful thesis. I think as infectious diseases have no boundaries and go across borders, looking at your curriculum vitae, you're a person who goes across borders as well. You've been to London, you've been to Sydney, you work in Qatar, you focus on India in your work, which is very alluring, and I'm very happy that you chose this university with an international focus to get your PhD. And with that, I'd also like to congratulate your international supervision team who have guided you through this process. It's an impressive piece of work. You've used lots of data and focused on the health equity part of the immunization services in India, which I found very interesting also to read. I've learned a lot. I'd like to ask my first question on chapter 4, where the outcome of what you call household catastrophic expenditure amazed me. And I did some reading, and while reading, I think I understand better what that exactly meant. But I also found that the way of measuring that can be done in different ways. Can you explain the methods you use to calculate this household catastrophic expenditure and why you chose that method in chapter 4?
Thank you very much for your kind words, and thank you very much, highly esteemed opponent, for your question. I'll start with the measurement of the income. Ideally, income should be measured, but unfortunately, income is not really available in our data set. So we use the expenditure for the household as per capita expenditure at the household level as a measure of income. And then we divided the households into quintiles. And for catastrophic expenditure, we used a cutoff of 10% greater than the non-medical consumption expenditure. So that was the method that we used. And the reason we used this method, it is a valid method. It has been used by several other researchers and was developed by one of the top economists who work with the World Bank, Owen O'Donnell. And we tested our hypothesis and the methods for 20% threshold also. And we realized that either we use 10% threshold or 20% threshold, there is marginal change in the proportion of households that fall below the catastrophic category. And catastrophic is generally defined in terms of a particular threshold above which the household has to pay payment out of pocket for seeking care. And we use this for infectious disease-related, both hospitalization and outpatient care. So I hope that...
Yeah, so you chose... So you did some sensitivity analysis also by changing the threshold of 10%.
To 20%.
Yeah, and it didn't really change the results.
It changed. So for example, at the 10% threshold, we found that there was like 0.7% of the household households for hospitalization reporting the catastrophe. We increased the threshold to 20%, it went down to 0.5%. So that's the change with the change in the threshold.
So I think then probably what you use is what I learned is the budget share approach. There's also seems to be a capacity to pay approach, which I've looked at. Have you tried to do a sensitivity analysis based on that, or is that an invalid method in your opinion?
Well, I mean, that's a very good approach. We agree with that, and we probably would use in our next research paper. But given the limitations of the data and the availability of the data with respect to specific line items, so for example, in our data set, we had information on the expenditure. We have information on expenditure for healthcare in terms of, say, consultation, diagnostic, medicine use, and so on and so forth. Information with regards to, say, transport and lodging and so on. But unfortunately, we didn't have the mechanisms to understand what is the true ability to pay. So that's why we used a threshold with respect to non-medical consumption expenditure. So we assume that non-medical consumption expenditure is the budget limit for them. Yeah. I hope that answers the question.
Yeah, that makes totally sense. And I mean, you could argue that maybe the results wouldn't change that much, but depending on the method you use. So can I ask you to read out loud Proposition 8, please?
Thank you very much for your suggestion, Professor. The Proposition 8, you said? This is access to safe water and sanitation, access to care and treatment, And financial risk protection are key to addressing infectious disease burden at the population level.
Thank you. I assume that all the factors you're mentioning here are of importance to you when you have this proposition. So I was just wondering, which one is of most importance?
Well, that's an amazing question. If I may take a step back to answer this question, in countries like ours and other low and middle income countries, there are diversity of reasons for infectious disease prevalence and spread of the infectious disease. All of these are really important, but from a public health perspective, I think it starts with access to safe water and sanitation, and then because it's something which is very core to the society, and ideally it's public good, so the government should invest in it. But other factors such as access to care are also important, and also newer technologies and newer interventions such as vaccines are also important.
So I would say that you probably put them in the right order. By beginning with the most important one from a public health perspective, and maybe ending with one where you have specific thoughts and ideas, because that's what I've seen in your presentation as well. If you look at the financial risk protection, lots of the data in your thesis is about expenditure and about the risk and also the pro-poor or the pro-rich. So what would be the, let's say, interventions you would apply to new schemes? For instance, you've mentioned the rotavirus initiation in the scheme to mitigate these financial risk protection measures. What would you advise your government to do?
Well, thank you for your suggestion and question, Professor. So ideally, we would want to have a universal health coverage like other developed nations in the Western Europe and other parts of the world. Unfortunately, given the expenditure on the health as a proportion of the GDP, if that is a constraint, a budgetary constraint at the government level, we would expect to have public insurance or social insurance to make sure that the households are protected from out-of-pocket expenditure. So those are two key policy recommendations that we have been proposing for several years. And again, demonstrating this in the era of pandemics, we again wanted to show that with the infectious diseases, which honors no boundaries and not an individual either, it is really important to protect households, because households are the core, I would say, foundation of an economy. So protecting households by protecting through financial risk mechanisms should protect the economy also. Thank you.
Thank you very much, and I'll like to give the word back to the chairman.
Thank you very much for your opposition, Professor Kals. Then we come to the following opponent, who's online, and also a member of the assessment committee. That's Professor Mathur, and he's Professor of Dental Public Health in the Queen Mary University of London, and that is in Great Britain. And thank you for coming all the way from London, albeit online. The University of Maastricht is always very glad to have guests from abroad. The floor is yours.
Thank you very much, Chair. I hope I'm audible now. Can you hear me well?
We hear you. You have your 9 minutes.
Okay. Thank you. Good afternoon, dear candidate. Let me start off by congratulating you on a wonderful thesis. You have done, it's very interesting to read. It is very engaging. It is technically sound, and I must congratulate you and your supervisors. Having a public health background, I've got a set of questions which alludes me towards my curiosity to understand more on the public health implication of your work. Let me start off by a simple question. You mentioned this in your background slide, but I want to hear from you that what was the core rationale for undertaking this research? What were the gaps you were trying to address? Or what are the open questions in existing literature you were trying to counter? And why did you just focus on immunization's impact on just out-of-pocket and antibiotic demand? So,
thank you very much, highly esteemed opponent. The key reason that we focused on the infectious disease-related out-of-pocket expenditure is in countries like India with the mixed health system and absence of insurance and universal health coverage, households bear the core burden of expenditure on healthcare. So we really wanted to understand why and how these households are managing these expenditures. So that's the reason why we focused on infectious diseases, especially in the era of the pandemics. We realized that in countries like India and other low and middle income countries, there is a burden of non-communicable disease and accidents and injuries and mental health. But with pandemics, there is an increasing burden of infectious diseases which remain there. And these, with the interventions that we have used in the recent past for infectious diseases, such as hard interventions like lockdowns and others, has really not helped. So we really wanted to see whether the interventions, which is preventive in nature, such as immunization, can help prevent these diseases, spread of these diseases, and can help households to bear the burden of these infectious diseases by investing in prevention and care rather than losing income because of wage loss or because of hospitalization or because of lockdowns that some countries have used during the pandemic. I hope that answers
Thank
the
you.
question.
Very well. Just a linked question to this. So when you were analyzing this and having some experience of understanding the national health policy and some understanding of the national immunization program in the country, at any point of time did you try to look into how this can reduce inequalities or how this exacerbates inequalities? Because one of the major things which we learned, when you talked about universal health coverage philosophy. And one of the major reasons why we want universal health coverage is to reduce these inequalities. So at any point in your analysis, you looked at inequalities and how, this is increasing inequalities, this excessive antibiotic demand.
Thank you very much for your question, Professor. So to answer the first part, we observed that the previous research on the immunization has largely looked at utilization part of the immunization services among the rich and poor, among different social strata in the country, among different states and districts. No one has really looked into the public subsidy component of the immunization services, whether being a publicly financed program, whether the immunization services are being consumed by rich people or being poor people. Because previous researchers probably have used a different data set. We use this data set in particular to understand this particular nuance so that we can advise the national government on focus more on full immunization coverage in districts which has high proportion of poor people, migrant people, vulnerable populations, so that the subsidy component is well distributed among the rich and the poor. With regards to the second question about the antibiotic policy, we know that we have a very robust antimicrobial stewardship policy at the hospital level. We have the national policy in terms of standard treatment guidelines. We also have a standard policy, very robust policy with regards to stringent prescription practices, so that in that policy, you can only prescribe or give an antibiotic to a person with prescription only. But unfortunately, in India, there are issues with regards to access of medicines also, especially in the rural areas, in the poor neighborhoods, and so on and so forth. And the cost of consultation is also sometimes a barrier to the households. So they directly go to a pharmacist and get antibiotics over the counter. So unfortunately, that is an area that still remains to be addressed through maybe a positive regulation to bring or to address the demand for the antibiotics, and probably the failure of the intensification of the immunization with respect to not reducing the demand of the antibiotics. I hope that answers the question.
Very well answered the question. This actually leads me to my second question, and this is regarding the data sets which you have used. Now, there is one data set which you have used, which is self-reported data set. The other data set which you have majorly used in your thesis, it comes from a private sector database. So can you just highlight some of the major limitations of using, these two kinds of very different data sets coming from different agencies? One is a public sector agency, one a private sector agency, and how might this have affected your results?
Thank you very much for your question, Professor. So the first data set that we use to understand the economic impact is it's a nationally representative data, and it has been collected for over decades, I would say more than 50, 70 years now by Ministry of Statistics and Implementation. It has a very good representation across all the states, districts, rich and poor neighborhoods, rural and urban areas, and so on and so forth. One limitation of this is self-reporting of the diseases and self-reporting of the expenditure. And that's the reason why we use expenditure as a proxy for the income, because the expenditure is a ceiling which a household could bear, so they can't expend more than they earn. So that part is taken care of. Unfortunately, because of the self-reporting, we understand that the estimates that we have given in our papers and in our thesis are like a lower bound, because in self-reporting, it's generally a tendency of household members to underreport the diseases, because sometimes they don't really think that this disease is a worrisome disease, especially an infectious disease such as a common cold or fever or something like that. So that could be an underestimation. With regards to the private sector data, it's a farmer track data which is collected by Market Research Agency. What we know from the agency is that there is a little underrepresentation of the rural side of the demand for, say, antibiotics, because these agencies use technology-based software to collect the retail sales of these molecules across the country. And given that the rural areas might not be well connected to their technology platform, so there could be an underrepresentation. So that's what we see. And we have reported in the limitation section.
Thank you. Thank you so much. Do I have time for one more question, Chair?
Yes, short question, short answer.
Yeah. So very quick, short question to you. You have used the term demand for antibiotics at many places in your thesis, in your dissertation, and as well as in your presentation. Now, how would you define and measure antibiotic demand? And what is the definition you have used in your study, or the measure which you have used?
Thank you very much for your question, Professor. We have used demand, which is a proxy for the sale, because we know that an antibiotic is a prescription-only medicine in other parts of the world. But in our country, because it is available over the counter also, so that's why we use the word demand. So if a person feels that he needs antibiotic, he either goes to a pharmacist and gets the medicine, or even he tells the doctor to prescribe an antibiotic. I'll stop here. Thank you.
Thank you very much. Thank you.
Thank you, Professor Mathieu, for your opposition. Now we go to the following opponent, also online, and also a member of the assessment committee. That's Dr. Saxena, and his expertise is community medicine and epidemiology in the Indian Institute of Public Health, and that is in Gandhinagar in India. And thank you for coming all the way from India, albeit online. The floor is yours.
Thank you very much. Thank you very much. And I extend my compliments and congratulations to Mr. Candidate and the supervisors for this wonderful piece of work. Thank you for giving me an opportunity to ask this query. It's a very precise, short query on your objective number 4, where you have tried to document the impact of Mission Indradhanush on antibiotic usage. And one of the policy implications that has been documented is better targeting of universal immunization program. I'd like to seek more explanation and more explicit comment on that. And follow-up question pertaining to same is, what additional value your piece of work actually adds when the newer vaccines have been included in the national immunization schedule within India? Thank you.
Thank you for your question, dear highly esteemed opponent. With regards to a specific question about Mission Indradhanush, so the Mission Indradhanush is a periodic intensification of the routine immunization program. Unfortunately, what we know from the previous surveys and the data, that there are still children who are not fully immunized, especially in hard-to-reach areas and especially in poorer neighborhoods. And there is a very little level of, I would say, vaccine hesitancy also in some set of populations. So this particular program targeted those very individuals and hard-to-reach areas, and it was not demonstrated by any other research work, that we demonstrated that this particular program had a positive impact by demonstrating that the sales of the vaccine in the private sector was going down. Because if that was not the case, the private sector would still have been flourishing with immunization services. So what we say is that given the set of individuals who need vaccine is a fixed cohort of 27 million approximately in India, if there is a reduction in the vaccine sales in the private sector, that automatically means that the households have shifted to the public sector. So that's what we have demonstrated to actually complement the national government and the program to say that this really has worked. With regards to, can you repeat the second part of the question? Sorry.
Yeah, I can. Thank you. So, my second query was, thanks for this response. My second query was, with the new vaccines that has been implicated in the national immunization schedule, what is your any specific policy recommendation that you could drive from the work you have already done? Thank you.
Thank you very much, Professor. We know that we have introduced at least 4 new antigens in the program. Unfortunately, there are still several other vaccines that still needs to be introduced in the program. So I think HPV is one of them, typhoid vaccine is one of them. There are several others we can discuss. The moot point is that the pace at which we are introducing vaccines because of our limitations or whatever reasons, I think that has to be expanded, that has to be fast-tracked, because we are demonstrating again and again that we have a very robust system for vaccine supply chains. We have very robust demand in the population, so ideally we should be doing more to introduce newer antigens. I'll stop here. Thank you.
Thank you. I have nothing to add. Thank you, sir.
Thank you for your opposition, Dr. Saxena. Now we come to the following opponent, who is also a member of the assessment committee. That's Dr. Den Heijer. He is a physician epidemiologist in public health and specializing in infectious disease at the University of Maastricht. And today he has also accepted the role of secretary of this committee, for which I am very grateful.
Thank you. Dear candidate, I would first like to congratulate you with your very interesting thesis on the economic burden of infectious diseases in Indian households and the impact of immunization on antibiotic use and out-of-pocket expenditures, and thereby also taking into account the equity purpose. So, with the current increasing trend of antimicrobial resistance and also vaccine hesitancy, what has been stated before, these are important themes regarding public health that we are dealing with right now. So, important work. In addition, I would also like to congratulate your team of supervisors. And with these teams regarding antibiotic use, vaccines, economic aspects, I expected the cover to be on these teams, but I see mainly nature. So perhaps you could explain what is meant by your cover.
Oh, dear highly esteemed opponent, thank you very much for your kind words and this particular question. Well, at the beginning of my career, I worked with WHO as a surveillance medical officer and was looking after the polio immunization program. And that was the year 2007. And the polio program has to reach each and every child to give the immunization, two drops of the vaccine. And I was working in a very, very remote area when one of the belts of the Ganges River, where you can't reach even by a vehicle. So you have to stop a vehicle, then you take a boat, and then you cross the river. And there are households over there doing farming. And we went there to give them polio drops because I was doing the surveillance of it. And I took that photograph over there. So that remains my cherished memory of working in the immunization program and immunization system. That's the reason I used that cover. I thought of using other covers, but that remained very cherished dream work that I did several years ago.
Thank you. So a very personal picture. Very nice, this explanation. Thank you. I would like to go to chapter 4 regarding some tables in the appendix. On page 104, there's table A5, where you give the percentage of children immunized with each vaccine on an individual level. What I noticed is that the percentage of children immunized drops quite sharply from birth, for example, the polio vaccine, until the booster dose, which has only has a percentage of just above 40%. You see the same trend also for the DPT, so the diphtheria, pertussis, tetanus vaccine. Could you explain this sharp drop in the vaccine coverage rate?
Thank you very much for your question, highly esteemed opponent. So, the universal immunization program expects the mother to bring the child for the vaccination. And this booster dose is given at, the oral polio vaccine and the TPT vaccine is given at 6 weeks, 10 weeks, and 14 weeks. And then the booster dose is after several months, generally at, say, 18 months. So what happened is, by that time, the mother usually, this data is recorded from the routine immunization card. So by that time, usually the mother don't really pay attention because it's a visit far away in the future or far away in the time, don't take that vaccine, or they have taken the vaccine, but unfortunately they don't have the record on the card because they have lost the card. And because the data collector wants or need a card as a proof, so they report that as usually not taken.
So it could be an artifact, so that because of not taking the card, it's not recorded, and that's why there's a drop. So, do you have also some data on seroprevalence, or that you have data that perhaps are more accurate than?
Professor, can you speak little loudly?
Yeah, you can answer.
Thank you very much. So the question that Professor asked is about this particular issue leading to the artifact in the data, and do we have any other proxy measure, which is hard to estimate? So to answer the question, Professor, we do have regular seroprevalence surveys, but they are usually done with regards to understanding, say, the efficacy of the vaccine, or to understand whether the vaccine cold chain has been maintained and it's reaching to right people at the right time. We have some data on the seroprevalence of polio, and that is what we used to actually decide where to have our polio rounds in the early days. But now it is not really done regularly. But if you want, I can actually look into the seroprevalence data to demonstrate what is the current seroprevalence rate.
Okay, that would be a nice, thank you. So, an additional question is regarding appendix table A7 on page 105. There you have the percentages of households reporting infectious disease by immunization status of the children. And overall, you see that in not fully immunized households, there's a higher prevalence of infectious diseases. But it's a bit surprised me that it was not the case for measles. And from my perspective, the MMR vaccine with measles in it is one of the strongest vaccines we have. So I was quite surprised that you didn't see that trend in for measles. Do you have an explanation, or could it be bias, or what's your opinion?
Thank you for this question, Professor. We looked at these estimates with great nuance, and we did this analysis a couple of times to really make sure that this should not be the case, because as you have pointed out, I also have the same feeling. But one thing that we have to note is that this data has two dimensions. One is the investigator who is at the household asking the parent, did you have this disease? So the thing with the measles is it is a fever with the rash. And there are several other fevers which present as fever with the rash. So probably the mother is reporting other diseases as fever with rash as measles, and the investigator is noting down that as measles, because that's the definition for them. So that's the reason for this discrepancy, if I may say.
Okay, that's very good to hear. We also, from the infectious disease department at the Public Health Service, we also state it's very important to do diagnostics with these children to know for sure that it's a measles diagnosis. So we also get phone calls from anxious parents who state that their child has measles. So yeah, I'm okay. That's a nice explanation, and I think
Yeah, there's time.
there's time. More than enough. Okay. Let's see. I have. Yeah, you've done the evaluation of the impact on health and economic outcome for the rotavirus vaccine. Which vaccine needs now the priority to get this evaluation? Because in your discussion you state that more vaccines or antigens must be evaluated in research. Yeah, what's the next? What's the next goal? What do you want to do in the upcoming period? What's your priority?
Thank you very much for your question, Professor. So, if I've understood the question correctly, so my priority as a researcher is to look for, several vaccines have been introduced. Two most important ones were rotavirus and the pneumococcal conjugate vaccine. So I would want to do evaluation for the pneumococcal conjugate vaccine as the next thing. But unfortunately, the self-reporting with the pneumonia is again tricky because it's a syndrome complex and several things could be reported as pneumonia, including common cough and cold. So that's a little harder for us. So we are waiting patiently to get some data from a real field evaluation by some other researchers to run this kind of analysis.
Because yeah, is this something that is given that's always syndromic, or could you also adapt the survey so that you can have more accurate data or more diagnostic data from the hospitals or lab results, for example? Is that a possibility?
Thank you for the suggestion, Professor. So we are looking at hospital-based surveillance, but that does not really truly represent the burden in the population because the severe cases come to hospital. That is the one thing, and the kind of analytical framework that we used is more ecological in nature to see whether the vaccine introduction is leading to changes in the disease prevalence. Unfortunately, the data on the disease, and especially the pneumococcus, is such a fragile organism, it's really hard to do diagnostic on it in our country because we don't have point-of-care rapid diagnostics to do discrimination between different pathogens leading to pneumonia. So it's getting trickier for us, but probably we'll do it with using the multicentric hospital-based surveillance data. And we'll link it to specific cities from where the data has been collected.
Okay, thank you. Yeah, I was also wondering whether there would be differential bias, so per group. I don't know if you have, yeah, because when there's in both classes a similar amount of bias, then your estimate is still quite accurate. So.
Oh, very true. Thank you for your suggestion, Professor. So what we have been trying to do is use a quasi-experimental design with multiple data points. So assuming that in the pre and the post-intervention period, the biases cancels out among the groups, as well as we have multiple data points to really understand how it is happening or doing over a period of time to really make an assessment about the causality, though it is still really hard to do those things.
Okay, thank you very much. Now I'll give the word back to the chairman.
Thank you very much for your opposition, Dr. Den Heijer. Now we come to the following opponent, and that is Professor Pavlova, and she's Professor of Health Economics and Equity in the Faculty of FHML at the University of Maastricht. The floor is yours.
Thank you. Dear candidate, My congratulations to you and to your supervisory team for this valuable dissertation. You have investigated an important topic with global relevance, which is related to the immunization, to the impact of immunization on antibiotic use and infectious diseases. And I was I find it very interesting to see that you have also taken an economic perspective on this topic, focusing on the out-of-pocket payments related to the topic that you study and also the impact on equity. All very important points. Although you focus on India, on the case of India, the evidence in your dissertation will definitely be important information for decision-making all over the world, also in other countries. I believe researchers and decision-makers around the globe can learn from what you have delivered in this dissertation. I would like to discuss with you some points that are related to out-of-pocket payments in their impacts, because this is also very much linked to the research that I have been doing. Very rightfully in your dissertation, you make certain recommendations about how to address the negative impacts of out-of-pocket payments. So I read, like in chapter 20, especially, I read recommendations like strongly pro-poor measures or financial risk protection package, reducing out-of-pocket payments. So these are usual recommendations that we read in research on out-of-pocket payments. And you also provide very good quality evidence, which actually give you the right, give you the base for making these kind of recommendations. I was wondering, however, how we are going to translate, how we could translate those kind of recommendations to the decision-making practice. For example, let's start with one recommendation right in chapter 3, the strongly pro-poor measures. I wonder then, how do you define who is poor? How feasible it is, and what challenges could be there? Maybe we can start with that question.
Thank you very much for your suggestions and question, highly esteemed opponent. So in India, the poor is defined by a poverty line, and the poverty line takes into consideration the bare minimum requirement of energy consumption that is needed for an individual, which is based on our Indian Council of Medical Research suggestion about 1800 kilocalories of the food. And then we have items related to, or the prices of the food basket, which we convert into terms of how much money an individual or a household has to pay to get those calories. And based on those recommendations, there is a poverty line. But individual states, because it's a union of states, the country, have their own poverty lines. And based on that, they decide who is poor. And then they target their policies, especially the government programs, based on that criteria of poorness, if I may say.
Yeah, thank you very much. So indeed, we see here already some challenges, but I'm glad to hear that there is some attempt to establish some objective measure. But it is also kind of tricky, because what about the people who are just above the poverty line? So we have this so-called at risk of poverty. If we focus too much on those who are under the poverty line, what happens with those who are just above the poverty line? How do you think that your dissertation shed some lights on it? Or if not, how you think you could deal with this kind of problem in future?
Thank you for your question, Professor. So we have been dealing with these problems of cutoff ever since we have been suggesting policy advice to the national and the state government. So another way of looking at it is generally what the governments do, they also have at the cutoff, the uncertainty levels. So they usually include all those people to give them the benefit. That's one way of it. Another way is generally in countries there could be, you can do geotagging, you know which are poor neighborhoods. Another way could be you can use the other benchmarks, such as we know in our country there is a system in which we measure people who are, say, scheduled castes and scheduled tribes and other backward classes. We can use those cutoffs. Another measure that has been recently used is the income level. So there are multiple measures that the government is trying to use to identify who really are the poor. But irrespective of the measure we choose, there are always certain set of people who are poor but fail to qualify. So that's really an unfortunate thing that we are still dealing with.
And don't you think that focusing on poor, however we define, will not create inequalities in the opposite direction?
Thank you, Professor. That's a very, I would say, interesting point to see it. Unfortunately, when we look at this divide between rich and poor, in our data we have used quintiles. So we have 5 quintiles, and we looked at what is happening in the richest versus poorest. And we have seen that the second poorest is also similarly worse as the most poorest. But as a national government, when we are collecting taxes and we are really given a job to govern by redistribution of that public money, what we need to do from the utilitarian perspective is to, from the angle of equity, we need to give it to the people who are worse off to bring them to a common level. So I think that is the right thing to do from the equity perspective. We are not really interested in equality. We want to bring those who are really below a certain threshold to a common level at the national level.
I'm very happy to hear that you are aware of the distinction between equity and equality, and that you brought that. Let's look at the other point, financial risk protection. That costs money, yeah, to ensure good financial risk protection, and especially to have a good mechanism to avoid stigmatization and to encourage people who are entitled to certain benefits to actually make use of them. To realize this, we need to take resources from somewhere. So what will be your suggestion? What you would sacrifice to make it possible to have a better financial protection for those who are using for your study?
Thank you very much for your question. So if I'm sitting in the Ministry of Finance, I can take a broader perspective of allocative efficiency. I can bring in resources from other sectors, which, depending on the ideology of my government, could say, well, you can invest more in the social security, let's get money from, say, private sector or from defense and from some other areas and redistribute in the social sector. If I am sitting at the level of, say, state where the money has already come and I can't do much about the allocative efficiency, probably I'll still want to invest more money in the interventions or the programs which give me more bang for my buck. So I probably would invest more in public health measures rather than building new tertiary care hospitals. So that's how I see reinvestments within the limited budget constraint. But there are different school of thoughts. Others could argue that you invest more in technology, invest more in manufacturing, invest more in economy, and you get money back, and then you do the social thing. But that's a point of perspective that we can take.
Yeah, and how feasible you think is to relocate resources from other sectors?
Thank you very much for your question. If I can see it from my country perspective, we have the annual budgetary thing, and within the annual budget, those who, I would say, can argue to the finance minister or the prime minister office.
You may finish your answer if you like.
They can get more money for their sector, and they can use different mechanisms to improve efficiency within the system to have a more equitable distribution.
Yeah, thank you very much. Thank you for your answer.
Thank you, Professor Pavlova, for your opposition. Dear candidate, Mr. Farooqui, the time appointed for the defense of your thesis has passed, and the degree committee will now withdraw to discuss the quality of your thesis and the way you defended it. And I ask you and your guests online to await the results of our deliberations and our return in this room. And with that, I suspend the meeting.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes.
Long road to the south side. 10 miles in my rearview mirror, I know what it felt like. My goals only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. The line, I know you know that I can't read your mind. Years can't fly by now, don't waste all your time. Cause I'll go the extra mile. Long road to the south side, 10 miles in my rearview mirror, I know what it felt like. My goals only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. On the dash, got my laces tied. Long road, I don't waste no time. Break rules because fate decides. With the team and we chase the light. I make a move, fall down, shake it off. I hate to lose, bad branch, break it off. No room for negativity, praise and love. Prepare for deep part cause we're taking off. Take the mileage, traveling so far from home. Gathering knowledge, other connections. I put the time in to get everything I ever hoped for. It's a challenge and we all in. It's a better future that we go for. And even though these nights seem long, I know that I am never on my own. Know you've won the battle once you've grown. South side, 10 miles in my rearview mirror, I know what it felt like. My goals only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. Long road to the south side, 10 miles in my rearview mirror, I know what it felt like. My goals only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. Years can't fly by now, don't waste all your time. Cause I'll go the extra mile.
I reopen this academic session. Dear candidate, Mr. Farooqui, the degree committee here present has assessed the quality of your thesis and the way you defended it, and then in view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor van Schaik is authorized to confer upon you this academic distinction in accordance with Dutch university custom. I invite Professor van Schaik to now take the floor.
Thank you. I first have two questions for you. Do you promise to work in accordance with the principles of scientific integrity at all times? To be careful and honest, transparent, independent, and responsible?
Yes, I promise.
Yes. By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Habib Hasan Farooqui, the degree of doctor, and grant you all rights attached by custom and law. As evidence of this, I now present you with the degree certificate signed by the rector, the secretary, and the other members of the committee, and affixed with the official seal of the university.
Thank you.
And on behalf of our supervision team, Professor Shiridaro Habib, he will give the laudatio. Shiri.
Members of the doctoral committee, esteemed faculty, supportive colleagues, cherished family, and wonderful friends, and most importantly, dear Habib. I'm filled with immense joy, admiration, and respect as I share this tribute today, not just as a friend, but also as a supportive supervisor and collaborator. Just moments ago, you successfully defended a dissertation that truly showcases the very best of what population health has to offer, a sharp, evidence-based intervention that addresses one of the most pressing public health challenges we face today: the rising burden of infectious diseases and antibiotic misuse within a vulnerable health financing system. Your thesis is not only timely, it is pressing, and it is perfect. Congratulations on this extraordinary accomplishment. The field is better because of your work, and the future more hopeful because of your voice in it. But to understand the true magnitude of today's achievement, one must trace your journey that has led here. Habib's story began not in ivory tower or in a policy boardroom, but in the narrow, bustling lanes of Bhopal, where he grew up in a home rich in values yet modest in means. From those early years, he carried forward an unshakable sense of empathy, a fierce determination to learn, coupled to a genius mindset and an intuitive sense of fairness and equality, a deep-rooted integrity, and eventually shaped his scientific and policy mindset. What sets him apart is not just the sharpness of his mind, but the clarity of his moral compass, a conviction that science must be in service of justice, that data must lead to action, and that research must be grounded in fairness and equity. There were no shortcuts, no privileges, but the journey is marked only by curiosity, perseverance, extensive reading, intellectual brilliance, and unwavering support of the beautiful family that he has, who has powered his dreams. Congratulations to his wife and two sons, who is 13 years old and an infant, both cheering from Doha while he defended the thesis. In addition to the excellent scientific expertise and academic qualifications, what distinguishes Habib is his steadfast dedication to others. He's not just an exceptional epidemiologist, but also a fiercely loyal friend. Anyone would be fortunate to have Habib in this corner. He has an uncanny ability to sense when there is someone in distress, even before they express it, whether it's a coworker facing a tight deadline, a friend experiencing difficulties, or a student feeling unsure about their path. He's always there to arrive first, quietly, selflessly, and fully engaged. He possesses a remarkable talent for ensuring those around and feel recognized, heard, and never isolated. Beneath his calm and composite facade is a passionate reader. He enjoys poetry, literature, and he can read anything that comes across. And he introduced me to William Dalrymple, because of which I learned more history than I learned from textbooks. His academic journey is remarkable. Started with Banaras Hindu University, then London School of Hygiene and Tropical Medicine and London School of Economics, then University of Sydney. And globally is well recognized with several committees on World Health Organization. But more than all of his accomplishments, he is grounded in humility and his quiet grace that he follows through his journey, which has made him a distinct person. In the end, what truly grateful for your commitment to PhD journey is, as supervisor and on behalf of Professor Uno and Professor Anup, I thank you for bringing your whole self to this journey. It has been a wonderful journey to see you as a scholar, problem solver, mentor, and a friend. Your contributions have genuinely made look all of us better, and the impact goes beyond just the footnotes. Dr. Habib Hasan Farooqui, your efforts are already creating waves in policy, programs, and individual lives. The world will benefit because of the presence of your voice. Please join me in celebrating a scientist of substance and heart, Dr. Habib Hasan Farooqui. Thank you so much.
Thank you very much, Professor Babu, for a very nice laudation. Dear Dr. Farooqui, also on behalf of the University of Maastricht, I congratulate you with the degree you have acquired, another important day in your impressive scientific career.
Thank you very much.
And I hope when you come back to your family, you can celebrate it and
Thank you very much.
enjoy this day. Congratulations also to your supervisors, Professor Van Schaik, Professor Babu, Dr. Karan, and of course your family, friends, colleagues online. They have watched a well-defended thesis. I would like to thank the opposition for all their work, and of course the PEDEL and the technical support team who made this online promotion possible. With that, I close this academic session. So we stay online for a photo. Take that. Technical support. Technical support. Goed zo, dankjewel.